Okay.
This meeting is being recorded.
Just letting you hear read it. Really. So we'll see.
Okay, so welcome and thank you for joining us today for the meeting of the New York City Health and Hospitals Equity, Diversity, and Inclusion Committee. Today's meeting is officially called to order. Please note for the record that Dr. Michelle Allen is represented Dr. Mitchell Katz in a voting capacity. So next on the agenda, I would like to propose a motion to adopt the minutes of the Equity, Diversity, and Inclusion Committee meeting held on October 17th, 2022. Let me get your vote, Dr. Allen,
Accept, yes.
Sally Hernandez Piñero,
Yes.
Frida Wang,
Yes.
yes, and Jose Pagan, yes. So minutes adopted. So next is a diversity and inclusion update from Ibelis Mendez Justiniano.
Good morning, everyone. Happy New Year to everyone. So today we're going to be providing you with an overview of 2022 in terms of broken down into language access, equity and access, training, communications, and events that were held. We're going to start off with language access and interpretation services covering the period of January through December of 2022. We fulfilled a total of 1,492,362 interpreter request calls, which when translated into minutes, go into 20,932 and 62 minutes. 20 million rather. The top three languages, they're on trend with the remainder of the 2022 year. So they are Spanish as the most common language requested. We had 1,151,923 Spanish requests fulfilled, which translates into 16,117,344 minutes. That's followed by Bengali requests at 49,198, which translates to 711,342 minutes. And thirdly, Mandarin requests fulfilled, 45,811, which translates to 639,301 minutes. So that's a large volume of interpreter requests.
Is this much larger than last year, the 1,000,004?
The 1,000,004, I would have to check back on last year's schedules and get back to you, but I believe it has increased. In terms of training, for the 2022 year, the training breakdown, we had a total of 218,892 completions, which means that 218,892 trainings were completed, not necessarily 218,000 employees. The top trainings were sexual harassment prevention and culturally responsive services. And I'd just like to note on the second line, that should actually be incumbent workers. We have new hires later on in the presentation towards the bottom. And so each employee is required to take sexual harassment prevention as well as culturally responsive services training on a yearly basis. When we hire new employees, they're required to take culturally responsive services as well as LGBTQ awareness for new hires. And so if you look overall, in addition to the required training, the most popular trainings are interreligious awareness for patient-centered care. We had 22,905 completions, followed by strategies for fostering inclusion in the workplace, 19,313, and then introduction to LGBTQ colleagues at 19,036. What's important to note here is that those trainings are not required. So the fact that our staff are taking them, that means that there is a high interest in those topics. And so, as you can see, we're monitoring progress and we're monitoring interest in the topics based on the number of completions per year. We're also looking at those trainings that do not have high numbers in terms of marketing them in different manners, maybe doing a little bit more outreach to make staff aware that they do exist. Yes. Oh, go ahead.
Just something quick. Let me note for the record that Dr. Michelle Morse is representing Ashwin Vasan, Dr. Ashwin Vasan. She's attending in a virtual capacity, listening only. Go ahead.
Thanks so much.
So only the top two lists are required?
Yes.
And the rest are, and how do the staff become aware of, is there emails or
Yes.
is it?
So there's communication that's sent on a yearly basis. We also have a dashboard on the Learning Academy site that indicates each of the trainings that's required. And then at each facility, there's liaisons that communicate on an ongoing basis with the staff and letting them know these are the annual trainings that are required.
So we just have 2 required annual trainings?
In terms of diversity and inclusion, there's more required trainings, but they fall outside the scope of diversity and inclusion.
And what's the criteria for training being required or mandatory?
So the criteria for a training being required or mandatory is either there's a regulatory agency that warrants training in that particular area, there is a law that warrants training in that particular area. So for example, in terms of sexual harassment prevention, every employer is to provide that. And then in H&H, what we've done is if senior leadership requests that a particular training become mandated, then that's the ultimate in terms of H&H, in terms of making it required. So it's not just a process where anyone can call us and say, we'd like to make this required. There's a vetting process that takes place.
And is there any, I'm concerned about unconscious bias. Is there any movement to make that mandatory?
So there's not a movement yet, but ironically enough, and I'm glad you asked, this year we're actually starting in March. We're starting with providing unconscious bias training to all of HR system-wide. So that will take place March, April, and May. And we're going to start off with providing unconscious bias strategies in hiring. And then the plan is once we complete HR training, then we're going to spread that out to all of the hiring managers so that we address that at the beginning of the life cycle of an employee. We're looking at making sure that when we bring them in the door, everyone is being provided an equitable space to be hired. And then from there, we're going to move towards expanding it system-wide.
Thank you, Luis.
Okay, so a further breakdown of that training. When we look at the participant ethnicity breakdown, the greatest number of employees completing the training is Black African American at 35%, Asian 19%, Hispanic 15%, White 14%, and American Indian or Alaska Native 1%, and unknown or unreported 35%. When we look at the gender breakdown, the majority of individuals participating or completing the training is female at 67%, male 32%, unknown 1%, and non-binary reporting 0%. When we look at the overall top titles completing the training, the largest number of the category is nurses at 20%, followed by physicians, fellows, at residents at 14%, PCAs, PCTs at 8%, clerical associates 6%, service aides 4%, and all other categories, clinical and non-clinical, 48%.
I had a couple of questions.
Yes.
I always like to look at the year before to see if there are differences and what they are. But in terms of the titles that complete, I guess 2 questions. One, is the ethnicity breakdown kind of commensurate? Does it track employee population breakdown? I don't know what the numbers are. That was my question as well.
Oh, okay.
Is this the same as the staff demographics?
So it pretty much mirrors it. I don't have the exact numbers, but I can definitely provide that to the group.
I'd be interested just to see also of the voluntary training, what the breakdown is.
Okay.
And the on the titles,
Mm-hmm.
you know, we have a big drop between like nurses and then PCAs and technicians. And again, I don't know if there's been an increase or if there's been extra outreach to try to increase those numbers. And then you have others at 48%, which is kind of, it's such a big number.
So we can look at that and we can provide an additional breakdown in terms of the other 48%. And we can also look at the trending from last year's. I don't have those numbers readily available, but I will be able to report if there's an increase or decrease.
Do we try to draw in staff below the nurse, you know,
Yes.
position level?
Oh, yes.
These are not the completion rates. These are the proportion of people in each group that completed the training,
Correct. Correct.
just to make clear.
I don't understand. What was that?
That 20% of the people that were
Completed.
trained were nurses,
Right.
just to make that clear.
Okay.
Dr. Allen, was that your
It
same
was the
question?
same. You know, 20% of our staff nurses. So just how does this relate to,
No, not 20% of our staff nurses. 20% of the population that completed the training were nurses.
but my question is, then, is that the same, does this represent the proportion of our staff who are nurses? Are 20% of our staff nurses, are 14% docs? Just to compare, because if, it's the same question with the ethnicity, perhaps 35% of our staff are Black. So that would mean all of our Black staff are actually taking the training.
I can bring that back and report at the next meeting.
Okay, yeah.
I had a quick question connected to feedback, because when I was doing the training, and I'm trying to remember if there was a step in which I could provide feedback about the content of the training, or at any point, how would I provide feedback on the training?
We have dedicated emails that you can provide service, let us know about. In addition to that, we have staff starting to go out and speak into different areas in terms of what would you like, and I'm going to speak about that later on in the presentation. We're actually going to be doing a gap assessment in terms of what are we providing now? Is it working? Do you want more trainings? What topics are you looking at? And as part of that assessment, we're also going to be asking in terms of the training that's out there now, how are our individuals not only reacting to it, but more importantly, how is it affecting their behavior? Because it's one thing to like a training, it's another thing to have training impact and change your behavior, which is really what we want to get to.
Thanks.
Okay, we can advance to the next slide in gender equity. So this year, I'm happy to say we completed the long-term care equality index submission, which this year was a greater difference than the previous applications. In prior years, that application was submitted by each post-acute care facility, and that was the extent of the application. In 2022, the application process changed. It became one application for all of H&H. So our Office of Diversity and Inclusion actually coordinated and worked with all of our post-acute facilities to provide the information necessary. In addition to that, there was a new component of the LEI, which was the LGBTQ executive brief training provided by SAGE. So in order for us to qualify for the LEI, all the leaders in post-acute needed to complete the training, and proof of that needed to be submitted to the Human Rights Commission. And I'm happy to say we had 100% on that. We had 153 leaders complete the post-acute training, and I have to say myself, I completed it. It was an excellent training, and we're going to see if we can bring that training to the masses. So we completed that, and we're waiting on word on whether or not it was awarded, and that should come in late spring or early summer. In addition to that, we finalized and released the transgender non-conforming inpatient assignment guidance document. And that's a document that's meant to assist the facilities when patients come in and they're looking to room in a particular area, whether it's female to female, male, female, based on what they identify with, and that's been released. In addition to that, we created a transgender nonconforming transition letter to support trans employees. So as we go out into the facilities and we speak about what we do, what we found is the comfort level for employees to come to us requesting assistance is increasing. And so we've had about 2 or 3 employees who are in the middle of their trans journey approach us for assistance in helping them get the support that they need during this journey. So for example, if an individual is on a trans journey and they started off as male and they're in their trans journey to a female, how would they like to be referred to? She, her, they, if it's non-conforming. And so what we did is we drafted a letter that we sent to leadership and said this individual, at their request, is in the middle of their journey, they would like to be referred to as XYZ moving forward. And we sat in some of the leadership meetings to really explain to people what does that mean when someone is transitioning. And that's been a new, as far as I've been in the ODI office, that's been something new that's been coming to us. And it's been very well received. We receive very positive feedback from the employees that we assisted, as well as the leadership, because now this gives them tools that they're able to really connect with these employees. So that's on the gender equity front. If we advance to the next slide, system level achievements. So for the month of October, we held a Hispanic Heritage Month panel, and we featured different staff speaking about their history, their culture, how their culture impacts how they show themselves at work. On 11/22, we acknowledged Transgender Week with a panel that was called Journey Towards Inclusivity with our transgender community. We had 84 attendees. And what was special about this particular panel is that we mixed our workforce that identified as transgender, but we also brought in individuals from 2 community-based organizations that also happened to be our patients. And so they spoke about their background, they spoke about the services that we received, and also provided advice to staff on how they can best serve them. In addition to that, on December 5th, we held an industry panel event focusing on nursing and medical lab technologists, and this was done in partnership with New York City Board of Education, and we had 75 attendees. And this is part of the focus of looking at minority and underrepresented youth in terms of bringing them into our workforce in the future in these positions that are critical to NYC Health and Hospitals, such as nursing and lab techs. And then on January 30th, I will be speaking at the Diversity, Equity, and Inclusion event for Empower, our new vendor for retirement services. In terms of communications, on 11/13, the week of 11/13 through 11/19, we sent out a communication on Transgender Awareness Week and Transgender Day of Remembrance. On November 21st, we had a Thanksgiving message from Dr. Katz. November 25th, we acknowledged Native American Heritage Month, and December 3rd, we celebrated International Day of Persons with Disabilities. I'm also happy to report for the year of 2022, based on all the work that we completed, we did submit for an award from the International Diversity and Inclusion Awards Group. And in front of you, you all have your 2023 diversity calendar. It will be distributed within the next 2 days. It's available in print and digitally. And one of the things that I want to highlight about this particular calendar, which is different than what we've done in the past, is that we put a call to all employees back in October. And we asked those employees, in terms of celebrating them, to submit either personal, whether religious observations or cultural observations, to submit pictures to us with a description of what the celebration is and who they are. And we had a wonderful response to that. So everyone that you see featured in this calendar is an H&H employee. So it's not only a celebration of the new year, it's a celebration of our diversity as an organization. And so you all have that, enjoy it. And then in terms of planning ahead, so it looks like it's going to be a busy time. One of the first things that we're working on this quarter is we're conducting a system-wide needs assessment in all the different areas that we've been focusing on. So that includes language access, training, gender equity, and health equity. As part of the system-wide needs assessment, I will be going out with the team. We're meeting with all different leaders across the system, finding out, reminding them of what we have available now. Also, identifying any gaps. What do they need? What are we not providing that needs to be addressed? And then in addition to that, we plan to participate in the American Hospital Association's Health Equity Roadmap Initiative. So this is an initiative that is being provided to really look at what are we doing as a healthcare organization, and it focuses on healthcare outcomes, health equity, diversity, and inclusion. And based on that roadmap, it includes an assessment. So we have to look at everything that we're doing as a system. And then we would share that with H&H. And what they will do is they will give us accessibility to different tool sets that they have to help us inform what the future strategy. So when we take the language access, when we take the system-wide needs assessment and the results of the health equity roadmap participation, that information will then inform what the updated ODI strategy should be because it identifies the gaps that we have in terms of the processes that we have available. In addition to that, we are also working on updating the diversity and inclusion website. We're also expanding training opportunities under the D&I umbrella. We're starting immediately with the launch of training for New York City Health and Hospitals behavioral health providers on clinical care, and that includes clinical care for LGBTQ patients, and that's being done in partnership with the Institute for Human Identity. Another training that we are going to be launching is that on gender pronouns, and that's becoming increasingly popular as individuals are coming forward and identifying themselves as the pronoun of choice. We have hired a new gender equity director, so now we are able to go back out into the community and begin our outreach with community-based organizations, foster stronger partnerships, let them know what the services that we have available, but also find out what the gaps are that we don't have that they're looking for. We're continuing to provide the medical interpreter skills training, but this year we're planning on expanding it to include Haitian. So 2 years ago, we started off with just providing Spanish. Last year, we were able to expand and include Russian, and then this year we will be expanding to include Haitian Creole. We're also looking forward to finalizing and publishing the Linguistic Access Library. And so that will be a central repository for staff who speak a second language and have been assessed in terms of their level of proficiency in that language so that we can, if we're looking for a particular language, we can go and we can look at who speaks that language and has been assessed to speak that language to the patients. Also, we have the creation of the Language Access Coordinator Toolkit. So this is a resource that's going to be provided to all language access coordinators in the system so that, again, when they're assisting staff and they're answering questions regarding linguistic access, they all have the tools that they need. We are also piloting the Language Assessment Initiative for bilingual clinicians in Gotham. And so what we've done is we've partnered with our Gotham partners, and we are working with our vendor partner to assess the clinicians that speak a second language. So obviously they don't have to go to a class, but it will be an assessment process. And these individuals that are deemed to speak the language at a level necessary to interpret or speak directly to the patient will then be included or highlighted for the appointments on the appointment site. So when patients call to make an appointment, we will have a list of vetted providers that speak a second language. So we're starting that with Gotham. The plan is to pilot it there. Once we look at the results and review it, then expand that system-wide. We're also piloting the restroom signage project, and that's per Executive Order 16 regarding single-sex facilities at Woodhall. And so what we found is that although we're in compliance, and I've actually done walkthroughs through myself, in some instances, the signage is not necessarily visible. So we found instances where maybe even the signage has been taken down. So we're now going back and looking at all the different facilities, looking at who has the identification posters, who does not, and making sure that we have very visible signage regarding the restroom signage. And so that concludes my report. Any questions?
I had a kind of a broader question about the issue of behavioral health as it relates both to our employees and to our patients, and the resistance on the part, oftentimes, of African American and Latino patients and perhaps employees. And I don't know if there's training that can be done, one, to sensitize our employees to the issue and to a level of awareness so that they can help patients kind of at least think about that as an issue. Maybe we've done that already, or it's not in your bailiwick, I'm not sure.
I think that would be one that I would have to look deeper to see if we offer it. Doesn't sound like we may specifically offer it in that area, but I would be happy to discuss that and see if we can put it in. That could be a part of our gap assessment.
Okay.
I want to commend you on the work that you're doing in this space. We've talked about what things have looked like, how we've improved. If we could have a documentation of what existed 5 years ago and what exists today, that would be really helpful, I think, to the board. Because from my perspective, I think you've done a lot and accomplished a lot. I don't have any specific questions, so not to give anybody more work. Having the fortune or misfortune to have spent some time in airports recently, and having a 3-year-old granddaughter where there's a need for family space, and a lot of our patients come with their families and their babies. This may not be for you, but while we're looking at signage, is there any talk of having signage where families can change their diapers, where dads can change diapers? You know, in the airports, they have these family restrooms where you can actually take your toddler. I don't know if that's a facilities question, Yvette, or if that's.
I think it's a combination. I believe that depending on how new the facility is and their infrastructure, those things are taken into account. Our challenge will probably be the much more established facilities, but I think it's something that we can give to facilities management. We can do an assessment to see if, you know, for example, the family area, family bathroom, is something that we can implement, just to make sure that if there are any building codes associated with it, that we actually are meeting those standards as well. So that's a good question.
And to go back to the transgender issue, I think there's a lot of room for improvement there. I have found that my own staff in OHS don't actually know what transgender means, if a transgender woman versus, so I applaud the beginning of the education, but would encourage more, and even all levels, maybe even come to the cabinet and give us a tutorial on what we're doing in the transgender world.
Sounds good.
Those are my only comments,
And the board.
Elise.
And the board.
And the board.
And the board.
Yes.
Okay. Happy to do so.
Just to comment on, I mean, I like the fact that you're thinking about the needs assessments and the what you can learn from the AHA as information that can lead to the health equity transformation model for the system. So that's commendable. I'm very curious as to whether you're doing more than what the AHA is doing or how useful it is, whatever the AHA is going to do. But I'm curious about it, and I think it's important to learn about what other systems are doing and ideas that they have. So I think hearing about what you're learning about how other systems do it and have a conversation in this group may be interesting at one of the community meetings in the future.
It's a very exciting project, and looking at the different pillars that they're focusing on, I can already see where we're, as a system, where I think that we're positioned to do really well, and areas where we have opportunities for improvement. So I'm actually very excited to see that as well.
See how, yeah. Okay, so thank you so much for the report. Is there any old business or new business?
Jill has her hand
I had my
I'm sorry.
hand up. Sorry. Yeah. Is there time?
Go ahead.
Okay. I just had 2 quick questions, and also similarly
The
impressed and
volume is
amazed.
too low, so I don't know exactly.
Is it?
Yeah, we cannot hear you well.
How about now? Is that better?
A little bit better if you get closer.
Okay.
Yeah,
I think this is where. Is that better? Okay.
Yeah.
Great. Happy New Year. Just also wanted to echo the appreciation for all the hard work and how impressed I am with the volume of work that you all are doing. The 2 quick questions I had. The first was you presented a bit about how interpretation services are being used an incredible volume. I was just curious if you have ways of assessing appropriateness of use, as in, what's the denominator, I guess. How do we know that interpreters are being used in all of the different encounters that are happening? So that's one question. And then the second question is actually more maybe a historical question, since I'm still somewhat new to New York City-ish. The second question is just, has there ever been a racial justice health equity training for the C-suite across H&H? So the hospital system I came from at Brigham and Women's, there was a extensive training that all C-suite leaders went through together around racial justice and health equity. So that second question is more a historical question. It might be for others at the table, but those were the two questions I wanted to put forward.
Okay, so the first question I can answer twofold. One is that we do receive reports, and we have reports that we analyze in terms of usage system-wide. So we know who is using language access services, not only when it comes to interpretation, but also when it comes to translation services. And then secondly, in terms of monitoring our KPIs for each contract, we meet regularly with each vendor. We discuss volume. We discuss any issues. We even discuss the length of time that it takes to connect with an interpreter, also looking at any barriers or any improvements that we have. In the last month, just in the last month alone, or last quarter, we actually met with several facilities and the language access vendor in terms of looking at if there are any gaps between the languages provided, the services provided, and what the facility is receiving. And right now we have had overall a large number of satisfied individuals. We have not received any issues or any complaints regarding language accessibility at the facilities.
Okay, thank you. I think my question was more, for example, if I'm rounding with the internal medicine team at Kings County, what I am often seeing is that the residents will only request an interpreter if I say, can you get the Spanish interpreter so we can interview this patient? So is there a way to track that?
So we have regular meetings with the language access coordinators. That is not one of the things that we are tracking right now, but we can absolutely add it to the agenda as an item for discussion.
So I think, Michelle, in the electronic medical record, there should be an item there, preferred language, and match that with whether an interpreter was provided or not. So it requires some kind of data mining from the EMR, but I think it's possible.
We should look into it.
Yeah,
Do
that
an
would be-
annual.
That sounds great.
And around your question around the C-suite, racial equity and health justice, is that correct? Have we done any trainings?
Well, I'm just curious. Well, yeah, I'm curious. I've seen a few different models at different health systems of getting kind of C-suite leadership in more intensive health equity and racial justice training. And I've seen it through the People's Institute, Groundwater Institute. There's a lot of different models out there that I've heard be very positive, but I just wasn't sure if the H&H C-suite and all the SVPs had been through that kind of a training at some point in recent years.
I can speak for 2022, and I'm sure, I know that we have not. I can't speak for prior years, but we can look into it.
So we did have Perceptions Institute come in and give a training around bias, implicit bias, several years ago. I think we are due for a refresh.
Let's look at a few models and see what's out there.
That sounds great. I'd be happy to support.
And I just want to bring something to our attention. We're talking about diversity and inclusion around our staff. I think we have some work to do with how we treat our patients. A couple of incidents have come across our desks around our biases around substance use, alcoholics, substance users, our biases when we treat patients who are overweight or suffering from obesity. I know we have a subcommittee that might be focusing on that, but I think there's room for improvement in addressing our clinical staff and how they approach our patients. Thanks.
I'm nodding, but if I have to verbalize, it's a yes. I think we should do that, by all means. I actually have a student that is really, I'll talk to you later about it, that is really interested in this whole idea of primary care connected to people that are, how do you address primary care issues with people with substance abuse
Right.
and use? And how do you provide care that is more comprehensive?
So I know
Places
Nicola
like this.
has done a lot of work around weight management and the words we use to describe patients who are obese. And instead of describing them as obese, to recognize they're suffering from a disease that leads to obesity, and how our biases interfere and how we subjectively label patients. And that is in the primary care setting as well as the inpatient care setting.
So maybe review the training that we do and see if there's any.
Yes.
I'm trying to remember if there's any component like that. There is, but
Do we create our own training modules, or are we using existing ones, or?
It's a combination of both. So we have internal subject matter experts that we reach out to, particularly when it comes to the LGBTQ training. We have individuals that are on board that are from that area that are able to help us inform in terms of the training provided. In addition to that, we also have an array of external partners that we have that are experts in the field and specialize in those areas, and we rely on them again to provide training. So it's a mixture.
so even it's for many of these topics that we're talking about, it feels like the online training is one way of approach. People have different learning styles, right? So, I mean, is that something that you've been thinking about also? Like, how do you approach issues like the ones Dr. Allen mentioned?
So even though online training is very useful in terms of getting awareness out to the masses, when it comes to diversity and inclusion training, a lot of that training, or a great deal of that training, is very sensitive in nature, and it lends itself to having a live instructor doing that. So the training that I was speaking about earlier, so it's the gender pronoun training and the one from behavioral health. Our gender equity team is going out into the facilities, and they're doing workshops and they're training in person. So it's something that we are paying attention to. We have to look at the capacity of the team as well when we structure these, because again, not only is it sensitive in nature, but it's also an area where you don't want to have too many people in a training, because then it will not allow that safe space that people need to actually have a profound dialogue. So those class sessions are a little bit limited in terms of size. So if you want to have a good group, you want to have no more than 20 individuals in a group. And so I currently have 2 gender equity specialists that go out and train. So it's been a little bit difficult just in terms of getting out into the masses, but we do have a pretty robust training schedule that's being created for 2023.
Okay, thank you. Is there any other questions?
None.
Okay, any old or new business to come before the committee? If not, then the meeting is adjourned. Thank you so much.
Great. Thank you.
Thank you.